Dear audience, today I would like to introduce you to my PhD topic, identifying critical points in the management of patients with liver diseases. My name is Petrana Martinekova. Currently, I am PhD student and medical tutor, and I work on my projects with the great help of my supervisor, Kristina Hadimasi, my SMS, Mahmoud Obeidat, and also our statistician team. My vision is to improve the care for patients with liver diseases with evidence-based, but also personalized approach. And my mission is to investigate the current evidence of micro and macronutrients in chronic liver disease and the early detection of bacterial infections in patients with liver cirrhosis. For my vision and my mission, I currently work on two projects. Both of them use the methodology of systematic review and meta-analysis. The first one, comprehensive analysis of vitamin D supplementation in patients with chronic liver disease. And the second one, diagnostic accuracy of biomarkers in cirrhotic patients with bacterial infectious. So let's start with the first project, vitamin D and chronic liver disease. We know that chronic liver disease led to almost 300,000 deaths in Europe in 2019. Also, on average, 2/3 of mortality occur below the age of 65 years. Therefore, our patients die prematurely. Vitamin D deficiency is prevalent in this population, and it can account for almost 50 to 86%. It was found that severe vitamin D deficiency was associated with all-cause increased risk of mortality in patients with liver cirrhosis with hazard ratio 2.30. On the other hand, the vitamin D receptor, which is localized in the nucleus, can regulate the expression of more than 200 genes of various tissues. Also, we know that the respected societies in Europe and in America both recommend the supplementation of vitamin D if the deficiency is really detected in this population, but the clear effect of this is uncertain. Therefore, we wanted to bring more insight and more clarity. So we asked the clinical question, can vitamin D supplementation improve the survival and outcomes in patients with chronic liver disease? And to answer this, we use PICO framework with the intervention being standard of care plus vitamin D supplementation and the control being standard of care plus placebo or no additional intervention. We looked on several outcomes, namely survival or changes in liver enzymes, liver steatosis, liver fibrosis, and more. And over here you can see our systematic search. So we conducted the search in November last year. We looked on 3 main databases, and our search key consisted of 3 domains, the last one dedicated to the process of randomization, as this was the only study design we decided to include in the analysis. Here you can see the flowchart of selection. At the end, with my co-investigator Mihaela Topala, we finished with 46 eligible articles. And over here you can also see our outcomes. Some of them we included in the final manuscript, main part of the manuscript. Some of them we placed in the supplementary material. Today I will present only 3 of them. So, as the hardest outcome, we had survival. And 8 randomized controlled trials investigated this outcome, and we decided to divide them into 6-month survival and the 12-month survival. As you can see, there was no better survival observed in the patients who were supplemented with the vitamin D. And I would also like to highlight on this slide that we have, for example, one main outlier is the study of Mohammed, which is including 6-month survival outcome. And you can see that over there the risk ratio was highest, or we actually can see that there was a better survival in the vitamin D supplemented patients, but this outlier only included a patient who suffered from spontaneous bacterial peritonitis, which was very interesting for us. Then, we also investigated the insulin resistance, which was measured by HOMA-ER. Overall, we included 12 randomized controlled trials in the analysis. 11 of them investigated in patients with non-alcoholic fatty liver disease. 1 of them investigated the outcome on patients with chronic hepatitis C. And we divided the outcome based on the length of supplementation into less than 3 months and more than 3 months vitamin D supplementation. Overall, we saw that the insulin resistance modestly decreased in the vitamin D supplemented group, and there was a higher decrease in those patients who were supplemented for the more prolonged period of time. With this result, we actually reached the statistical significant level. On the other hand, the level was, or the effect were modest, but so far we don't have approved drug for the treatment of non-alcoholic fatty liver disease, so we need to very carefully interpret the results. And as the last outcome I will present today, we actually also look on the liver enzymes. Here you can see the summary forest plot. And what we found out was that there was a decrease, or bigger decrease, in the liver enzyme observed in the supplemented patients. We were able to include into analysis like 8 randomized control trials for alkaline phosphatase, but also like 20 randomized control trials for alanine aminotransferase. And we reached a statistical significant level for the ALT and GGT as well. So, as the strength and limitation, as every study has the strength and limitation, I would like to acknowledge that even though there was previously published meta-analysis, with this meta-analysis we were able to include 12 more randomized controlled trials with more than 1,600 patients. Also, we looked on more outcomes, and one of them, for example, liver statosis and fibrosis, which I presented in the last progress report, they were investigated or evaluated for the first time. We also aimed to perform subgroup analysis. We were able to do it for the length of intervention. On the other hand, we were not able to perform it for the form of vitamin D because the majority of the study used cholecalciferol as the main form. The main limitation for our study would be the differences in the form and the way of administration of vitamin D, also moderate to high heterogeneity for the several outcomes, and also that a lot of studies included only small sample sizes. And we lack the data for alcoholic liver disease or hepatitis B, which we know that there are prevalent causes of liver disorder in European population. So, as a conclusion, we can say vitamin D does not improve survival in the patient of concern. Also, we saw that it can ameliorate the insulin sensitivity, especially in the non-alcoholic fatty liver disease patient, and it may reduce or better reduce the liver enzymes such as ALT or GGT. We would like to highlight that for the clinical practice, even though it is recommended to supplement this vitamin D, still it's not sure when to measure, if to measure in an inpatient or outpatient patient. So this would be one implementation to create the optimal protocol. And the second would be we highlight the gaps of knowledge. We highlight those outcomes which might be interesting. Obviously, not all the outcomes show the significant differences, but we would like to focus the further research on those outcomes, such as liver statosis, fibrosis, or insulin sensitivity. And currently, the article draft is finished. Now it's with my supervisor, and we plan to submit it for internal review within the 2 weeks. The next project I will just quickly introduce to you, the diagnostic accuracy of biomarkers in cirrhotic patients with bacterial infection. We know that our patient died prematurely, and it was shown, or in the literature you can find that almost 30 to 50% of them died due to bacterial infection. Also, bacterial infection is acknowledged as the main precipitant factor for acute and chronic liver failure. Our patient can suffer from any type of the infection, but to recognize the infection in our population is pretty difficult, also because some clinical signs and symptoms can be present without having the real infection. And we know that the prevalence of multi-drug resistant bacteria has increased from 30 to almost 40% in the population. So we want to know what is the role of biomarkers, how they can help us to give the antibiotics early enough to our patient to reduce mortality, but to not provide them in the patient who does not have the real infection. And we would like to investigate several biomarkers such as presepsin, CRP or procalcitonin, and the others as well. We have conducted the search, and also now we are working on the title abstract selection, which will be finished within this week. So I would like to thank you for your attention, and also I would finish with the quote of Primo Levi: "If understanding is impossible, knowing is necessary." Thank you for the attention.
Thank you. This was a very interesting presentation. I know it's early in your second project, but I was wondering if there are not only single-factor prediction models, but multifactorial ones. So not only looking at CRP or procalcitonin, but a combined measure of these, because whenever such tools are available, they usually are stronger predictors than single-value models.
So thank you very much for the question. It's very interesting, and to be honest, we were more focused on the biomarkers itself, or we were also focused if there is a study which measures the dynamics of, for example, procalcitonin or CRP, because we know that with our search by now, with title abstract selection, I can say that we will have about 400 eligible articles for the full text selection. So it's a very interesting point, and I may look the literature, but we don't plan to implement it right now, maybe in the future as a project, because you are right that they can have better prediction. We can also decide based on the results of this project. Thank you.
Congratulations for your work, and I would like to ask you, how do you think that vitamin D is exerting a hepatoprotective effect? Like if you consider the reduction in the hepatic enzymes, the GT and the alkylic phosphatase.
Like we know that, for example, this vitamin D can influence the multiple like genes or multiple proteins. And for example, I looked into the topic of this insulin resistance when I was writing the manuscript, and we found out that vitamin D, actually with the connection of some other like contributors, there are present in the genes, there are present like vitamin D response elements, which influence the secretion or the production of the insulin itself. So there is the one way how it can influence this insulin sensitivity. And I believe that there are more, but I also need to look into the topic, like if it has ability to kind of stabilize the disease itself.
It can also have effect on perhaps bile acids even?
Sorry?
Can it have effect on bile acid metabolism and transport?
Yeah, that's a great point. Yeah.
So what I don't understand is that you say that the guideline suggests vitamin D supplementation, and I'm not sure what that recommendation is based on. If you look up the references for that recommendation, but looking at the results of your first project, just leaves question marks regarding that recommendation. Say what, when, to whom, how much, why. So is the conclusion, should it not be that the recommendation of the guideline is not based on any evidence, proper evidence yet?
I'm very happy that you pointed this out, because that's true. Like, we are recommending something that we are not really sure about. Like, we don't have very high level of the evidence. As I checked the guideline themselves, they mostly focus on the observational studies. And now we have the meta-analysis with the randomized controlled trials. There are like 46 of them, which means that we have like 41 original articles, because some of them, they were like published more time with the different outcomes. And the majority of them, like 70% of them almost, are based in Asia. So we cannot really generalize this into the European population or the North American population. We have only like 7 studies approximately from the Europe and 1 study from the United States. So mostly it's like telling us that more research is needed. We also pointed out like which outcomes might be interested. Like, for example, lipid profile, we haven't seen any difference, and we can investigate the outcomes that we've seen, like steatosis. But we can say like more research is needed to be sure when to give this vitamin D supplementation. So I agree with you.
Would you expect any differences regarding vitamin D supplementation in different etiologies of chronic liver disease? Because that was an interesting point, insulin resistance. So you might expect more effect on metabolic liver disease than viral or alcoholic or any other type of autoimmune liver diseases.
Like generally speaking, we know that the guidelines recommend this in cholestatic liver disease. But on the other hand, based on our evidence or our finding, we don't have like a lot of like autoimmune disorders, primarily biliary cholangitis, etc. So we cannot really answer this question right now. We have 17 randomized controlled trials on non-alcoholic fatty liver disease. So over there, we can be more certain. We have 13 on chronic hepatitis C, and the rest we have like the minimum number, and almost no study focused on only cholestatic liver disease, such as primary biliary cholangitis, etc. So we have this recommendation, but then we have randomized controlled trials.
But have you performed subgroup analysis based on etiologies? It would be interesting to add.
So far, we did not perform this. We have the form of vitamin D, and we have the time, the period of the intervention. Regarding this, we have found that, for example, for the different etiologies, we have only 1 or 2 studies. So it's not recommended out of our statistician to really perform this subgroup, because we will have NAFLD and we will have 2 studies for the other groups. So we cannot.